So I'm going to go first, and then Dr. Smith, our chief resident, will give a case presentation. We hopefully will follow up this 1 hour conference. Okay, so my topic this afternoon is carotid endarterectomy versus carotid artery stenting. So which one should we choose and when? So that's kind of always some debates. So which one is better, or when should we go, the benefits and risks, and which one should we use for this patient? And hopefully, after this, we have a better understanding. So I would like everybody just keep in mind, so remember this 80-20 rules, okay? For stroke, usually it's 80% is ischemic and 20% is hemorrhagic, okay? For 80% of strokes, so for the 80% total ischemic strokes, 80% is due to intracranial vascular stenotic disease, and 20% is from carotid artery stenosis. For carotid stenotic disease caused ischemic stroke, 80% of them is due to distal embolization. So a small piece of clot or plaque breakdown flush into the small vessels in the brain. And 20% is due to global ischemia. So we have to remember this, okay? And also for this carotid stenotic disease caused ischemic stroke, less than 20% of the patient present with some warning signs or symptoms, TIA, amaurosis fugax, and 80% of them just present with stroke. They come in with stroke because of carotid issues. So just remember this roughly, it's 80-20% rules, okay? Okay, let's just briefly review the history. Dr. Hunt first described at very early days, so we call that intermittent cerebral claudication. Now we call it TIA, all right? And he was the first one to publish the paper talk about this TIA patient was proved to have carotid artery stenosis in 1914. And Dr. Moniz, and I believe you guys, Dr. D will know better. He was the first one performed a carotid artery angiogram in 1927. All right, so there have been a lot of debates and battles during this development of carotid artery diagnosis, the disease diagnosis and treatment. So the first big debate was who was the first one did a carotid endarterectomy. So basically, Dr. Iscott published the first case report in 1954. However, let's say his team, and Dr. DeBicki, we all know him, right? He's a big cardiovascular guy. But he said he did the first one in 1953, but he didn't publish something until 1959. But he still claimed that he was the first one did the carotid endarterectomy. But based on this documentation, we still should give the credit to Dr. Iscott because he was the one first published. That's so far up to date. We still cannot, debate. If you read some papers still talking about Dr. DeBicki was the first one, but most papers still think Dr. Iscott was the first one. Okay, and after that, there was clinical, not just one clinical trial, so many clinical trials focus on the CEA, carotid endarterectomy, versus medical treatment before carotid artery stenting got approved to treat this problem. There's a big debate. So a lot of famous clinical trials was done in 1970s and 80s. So the big ones, as you can see here, the NASAD is the one we all know. Okay, I just cannot have. Where's, okay. It's a North American clinical trial, okay? That's, this 4 studies, 2 were done in the United States and 2 were done in Europe. And all of them showed benefits from carotid endarterectomy versus medical management. Actually, this NASA study was determined 2 years after study started, and it was not finished because this clearly showed carotid endarterectomy benefit the patient compared with pure medical management. So this study was actually determined during that study. So that's all these studies working on the symptomatic carotid stenosis and no, actually, so this 2 study on asymptomatic, 2 study on symptomatic, all of them showed beneficial from carotid endarterectomy. You don't have to remember all these numbers, but you can see that there were significant risk reduction in the surgical group compared with medical groups. So after this clinical trials, both for symptomatic and asymptomatic patient, obviously carotid endarterectomy won the battle over medical treatment. Since then, the carotid endarterectomy case numbers significantly and rapidly increased in 1980s and 1990s. In the United States, as you can see, over 200,000 cases per year in the United States. And you can do either like we call the traditional longitudinal incision and a carotid endarterectomy, or you can do a eversion, do a transection, and then remove the plaque and do a ring precision. We call that eversion. So it's a different techniques, but the surgery has been done in many, many patients compared with before. So even though after that, the surgery, we know surgery is better than medical treatment, but for surgical technique itself, it still has some debates. Patch or no patch, shunt or no shunt, longitudinal, like I mentioned, traditional way, or eversion like this. Okay, general versus regional anesthesia, reverse heparin or not. All this, some still going on. So but now clearly patch is better than primary closure because it's already showed the recurrent stenosis rate is significantly lower than without patch. And 80% of the surgeons are doing traditional way because if you have a long lesion, you can always extend it, the incision, the arteriotomy, and remove the plaque. But some centers, especially in Albany, they do most of this inversion. The good thing is you don't have to make long incision. It's quicker, and you can remove the plaque and re-implant this to the common carotid artery. The downside is if you have a long lesion, it may not be completely remove the plaque, and sometimes you generate the flap, and that can cause occlusion as well. But the clinical study shows no significant difference in the clinical outcomes. So it depends the surgeon's preference. But now we all do this traditional way. Occasionally, maybe do a eversion technique, especially you have a redundant carotid that you can transect, remove a piece of that, and then reimplant back. So, okay, we still have a lot of debates for surgery itself. And in 2004, carotid artery stent was approved by FDA. And currently in the United States, total 135,000 interventions, including carotid artery stenting and coronary artery endarterectomy. The total number compared with the cases done in 1990s is significantly decreased because we have better medications. A lot of patients, just especially high-risk patients, we treat with medical management. Okay, and currently we can see still probably close to 90% of patients receiving carotid endarterectomy a little over 10% patient got a carotid artery staining. And this keep change. So now, we have this new battle. So which one is better? Who should get a carotid artery staining? Who should get carotid endarterectomy? As I showed, the last slides showed close to 90% got carotid endarterectomy. That's based on the clinical trials we have now. Let's see. There's so many clinical trials compare the CEA versus CAS. It all depends on what endpoints you look for. Let's see. A is analyze the stroke rate. Actually, almost all the clinical trials showed the carotid artery staining has a little higher rate of stroke compared with open surgery. But the argument is during the early time when we just start the carotid artery staining, a lot of clinical trials were done without cerebral protection devices, no filter wires in there. That's why you got more stroke rate. That's one of the arguments. And compare with the total major stroke and the death, is a B, also showed this, the majority of this clinical trials still favored carotid endarterectomy versus carotid artery staining. But if you analyze the data to compare this MI, and most patients with carotid endarterectomy, they need general anesthesia, then patients would develop myocardial infarction more than that in the group of carotid artery staining. That's understandable. And also cranial nerve injury is almost you are never seen in carotid artery staining, but you see more in carotid endarterectomy. So just based on what endpoint you're looking for, and you got the different outcomes. But generally speaking, so far, based on current studies and past clinical trials, most patients still favored carotid endarterectomy. I used a battle word before. That's not from me. Let's take a look. This is Dr. Weiss, I believe most of us know. And after Dr. DeBicki passed away, and Dr. Weiss probably is the #1 vascular surgeon in the world. We know Weiss meeting in New York. We have interventional radiologists, cardiologists, vascular surgeons all come to the meeting. Weiss is a big vascular surgeon, and he used this. He said carotid artery staining may be losing the battle against carotid artery endarterectomy for management of symptomatic carotid artery stenosis. Why? Because all the clinical trials compare the carotid artery endarterectomy versus carotid artery staining. They focus on the symptomatic patient. That's why they got, like I mentioned earlier, the stroke rate and the death rate in carotid endarterectomy group is lower than carotid artery staining patient. And here it's like a CREST study. It's a carotid artery revascularization endarterectomy versus staining trial. And this study is currently the most important clinical trial. The first phase they're working on to compare the endarterectomy versus CAS in symptomatic patient. Now they're doing the second phase, basically working on asymptomatic patient, enrolling the asymptomatic patient, and the data showed it's not finalized yet, completely yet, but the midterm outcome showed the coronary artery staining can achieve comparable outcomes compared with carotid artery endarterectomy, even in asymptomatic patients. Okay, we are waiting for more data to support this. So that's why some said, well, CREST saved CAS. But still, some cardiologists have a totally different opinion, they said the carotid artery stenting will replace the carotid endarterectomy. This is all based on how to interpret the outcomes and clinical trial data, how to analyze and interpret it. So now what are we going to do? So we have all different opinions, recommendations, and also from different societies, they have different guidelines. Now, I went to NCVH meeting and we talk about carotid artery stenosis. So we say, what are we supposed to do? I go with Vascular Society guidelines, and the cardiologist said, yeah, I think all of them should have stents. So we're not talking about the same thing. So from our stand, Society for Vascular Surgery guidelines, which is published on JVS in 2011, but so far we have not gotten any new update yet. We're still based on this. The indications for interventions, asymptomatic patient, if less than 60%, or symptomatic patient less than 50%, we don't do endarterectomy or carotid artery stenting. The treatment should be medical management. Don't try to push the patient to operating room. Okay, especially now we increase the threshold even more because we got better medications with beta blocker, statins to stabilize the plaque, and the Plavix stronger antiplatelet medication. And the medical management outcomes is better, especially in selected patient group, is close to carotid artery stenting or carotid endarterectomy. So some surgeons even say they don't operate on the patient asymptomatic with severe carotid artery stenosis anymore, unless the referral physician forced you or family really wants to have that done. So for asymptomatic patient greater than 60%, if they are otherwise with a good healthy and the 3-year life expectancy, have over 3-year life expectancy, and here that's from the study. I explained this why older than 70 years old you prefer to have a surgery, but less than 70 years old you don't. This is kind of controversial. This is all based on the clinical study. They did a subgroup analysis for patients less than 68 years old. Basically, the carotid artery stenting has more complications than the patient older than 68 years old. It's kind of a little confused, but that's what the study showed. That's why these guidelines are based on that. I don't take this seriously. I mean, I still question. It doesn't make sense, right? So you do carotid artery stenting, and then why you have this patient less than 68 years old about worse outcome. We cannot explain this, but that's a guideline. We still questioning about this. For long lesions, if the lesions are over 15 millimeter, and the study showed the stroke rate is higher if you do carotid artery stenting. And for soft plaque, unstable, ulcerated, and CAS has a higher rate of stroke as well. So that's why we recommend those patients to have a CEA, have a longer life expectancy, older than 70 years old, long lesion, and a soft plaque. Then we should do, and greater than 60%, then we do carotid endarterectomy. For symptomatic stenosis greater than 50%, a good risk patient, we still recommend CEA. But for symptomatic stenosis greater than 50%, but a high risk patient, we're talking about symptomatic, okay? So for symptomatic, severe and credible carotid artery disease, CHF, severe COPD, then we do CAS, carotid artery stenting. That's a systemic high-risk patient. For still symptomatic patient greater than 50% stenosis with the regional or anatomic high-risk patient like this, patient had tracheostoma and previous neck surgery, like a neck dissection or bilateral thyroidectomy or previous carotid surgery, or patient had the neck radiation or prior cranial nerve injury from a thyroid surgery or carotid surgery, or high lesions above the C2 level, that puts you on much higher risk to have complications if you do an open surgery. Those patients we call anatomic high risk, and we recommend have a coronary artery stenting. Okay, for asymptomatic, greater than 60% stenosis, high risk patient. Now we're back to here. We got asymptomatic patient, high risk, high grade stenosis, good risk, we recommend a CEA. Symptomatic, high grade stenosis, if it's a good risk, we recommend CEA, but the high risk, either systemic or anatomic high risk, we recommend CAS. But what about the asymptomatic, high risk, high grade stenosis, high risk patient? What do we do? Should we do a CAS or CEA? The answer is we treat with medical management, no intervene. Even if the patient have 80%, 90% stenosis, but the severe coronary artery disease and a COPD cannot tolerate anesthesia, then we don't intervene. We treat with medical management. As I mentioned earlier, we have a better medications so we can handle that. Okay. So in summary, for CA, as we used for good risk patient, actually it's most of the patient, and a patient greater than older than 70 years old, lesions longer than 15 millimeter, and an unstable plaque. For CAS, we used for high-risk symptomatic patient with severe COPD, severe coronary artery disease, and a CHF, or anatomic high risk. Okay, so which is better? So after this, we want to see, there's no single gold standard for the treatment of carotid artery stenosis. I don't want to pick up, I don't want to say which one is better of the another. And both CA or CAS have advantages and disadvantages. The key is not which one is better, but which one is more appropriate to a particular patient. Okay, so choose the best treatment based on the patient's situation. Like I mentioned, like we focused before and we emphasized multiple times, if it's asymptomatic high-risk patient, we prefer to treat with some medical management. For asymptomatic or symptomatic good risk patient, then should be CEA, and a high-risk patient, we go with CAS. Let's just briefly review this, and I'll be happy to answer all the questions you may have. Thank you very much. Questions?
Thank you for this first class lecture on biology and management for lab. Wonderful. Very thorough, very well organized, and I think we learned a lot.
Thanks. I know you guys, as an interventional radiologist or resident, you probably will have questions when you take your in-service or board exams. But that's so far we have, to treat. The CREST trial basically is the most important one, like I said, is still ongoing. So, and we have a different clinical trial, like a SPACE 2 is compare the carotid artery endarterectomy, stenting, and optimal medical management. So like I said, early clinical trials, to use the old medications, but now we have a better medications, and then that's why we start enrolling patient with high-risk patient and cannot tolerate surgery and treat with its sustaining medications, beta blocker, and antiplatelets to see if the outcomes are different. So we're waiting for space to give us some better. Yeah, Dr. Zhang.
Right after stenting, do we use those distal embolization protection devices?
Yeah, no, it's the standard procedure. So all the no clinical trials now they have to use, otherwise they won't approve, because it's already clearly showed the protection device decrease the rate of stroke. If you do clinical study without that, you basically put the patient on risk to have a stroke. So that's not allowed to do. So all the carotid artery stenting procedures or clinical studies, you have to use protection devices. You have different devices though, but you got to use one of them to protect the patient. Thanks.
Currently, the health insurance companies, are they reimbursing or paying or covering for these procedures, the carotid stent?
Yes, it's the carotid artery stenting procedure. Actually, it was approved by FDA in 2004. It's one of the options for carotid artery stenosis. I think if I think Medicare, Medicaid all pay for it. As long as you document symptomatic high-risk patient, they'll pay for it.
Well, usually angiography is the gold standard for carotid stenosis, but which imaging modality do you use now? For characterization of the plaque, or grading the percentage of stenosis?
That's a very good question. So actually, now in the United States, I don't know the other countries. I know a lot of Asian countries they use a CTA or angio, but in the United States, majority of our patients, we make decision to go to surgery or not just based on ultrasound. So ultrasound is adequate in probably close to 80% of patients. So we don't need any other studies. So ultrasound showed this high-grade stenosis, and we go with that. But if ultrasound showed this, and I cannot give you exact, the percentage, then we may need to order a second imaging study. Like I said, this heavily calcified plaque, unable to determine the percentage of stenosis. Then we order another study to improve. Or patient is symptomatic with a history of TIA, amaurosis fugax, but ultrasound showed that 50% is kind of, unclear. Then we may order another study as well. So, but the most
Do
efficient.
your studies include angio-CT of the neck?
Some patients we do angio. Yes, angio, DSA is still gold standard. Okay, so CTA, as we know, is not good for calcified lesion, right? So it's still pretty hard. And MR is not as frequently used as CTA, but the accuracy reportedly is the same as the CTA. So you can use either MRA or CTA just based on your center's experience or preferences. You can just add one more on, but DSA still is gold standard, especially if a patient already is high risk, and you think a patient probably will benefit from CAS. I just book the patient for angiogram and a possible artery stenting at the same time before I see severe stenosis. I don't know, Dr. Tang, what do you? Yeah.
No, I think I agree with you.
Yeah.
Can you talk a little bit about combined severe coronary artery disease and carotid?
Yeah.
In the past, we do combine CABG and CA. There
Yeah.
are some people that are talking about doing stenting before CABG.
Right. Based on this, clinical guidelines, like several years ago, like 5, 10 years ago, we always go with the carotid first, and then so go whichever one is symptomatic. If you have a patient with coronary artery disease and stable angina, and then you treat that first, and then you do a carotid endarterectomy. But if you have a patient came in with TIA, but the coronary artery stenosis asymptomatic, then you treat a carotid first. Usually we go first and have a interventional cardiologist or cardiac surgeon to fix the coronary artery. But in the after that, Dr. Ricada, who is chairman at the Georgetown University, he's a vascular surgeon, basically did a lot of research on carotid endarterectomy, and they published a paper and compared this carotid staged surgery with the combined procedures, and then they showed combined endarterectomy followed with coronary artery bypass immediately at the same siting have a similar outcomes. With that, you do carotid endarterectomy first and then coronary artery bypass. So that's now if you have carotid artery stenosis and coronary artery stenosis, both symptomatic or severe diseased, you can do at the same siting with the carotid artery endarterectomy go first and then CABG to follow. And more recently, some study also showed if you do have coronary artery disease, symptomatic unstable angina, and you think it can be fixed with catheter-based technique, then go for it. Okay, I think that's a new data to support. If you have unstable angina, carotid artery severe stenosis, and the coronary disease can be treated with standing, then you go that first and then do carotid endarterectomy. If your coronary artery disease cannot be treated with standing, you have to do an open CABG, then you still go with carotid artery first, and then to do a CABG. You can do a combined procedure, but still with the CA go first. Right? Yeah, I think that's a little kind of confused about that. Yeah. Yeah. Any others? Okay, thank you. Now we have Dr. Patrick Smith that will give us a presentation about the case. Yeah.
Thank you for the opportunity to present today. We're going to present a case that we took care of recently on a hepatic artery aneurysm. Just a quick background about hepatic artery aneurysms. They make up about 20% of splenic aneurysms, which is second most common behind the splenic artery aneurysms. Pretty low incidence. It's suspected to be around 0.4%, although we don't really know the true incidence. It does seem to be increasing a little bit due to the increase in hepatobiliary instrumentation and manipulation. 3/4 are in the extrahepatic vasculature, and of those, 63% are in the common hepatic artery. There's a little bit increased chance in males to females, a ratio of 3-2, and the rate of rupture is actually highest of any of the splenic aneurysms. It ranges between 20 and 80% in different series. Also, mean age of presentation excluding trauma is 60 years old. The majority are identified incidentally on cross-sectional imaging, although they'll frequently become symptomatic. When they are rapidly enlarging, patients can have abdominal discomfort and back pain. Rupture can be seen with equal frequency to peritoneal cavity or hepatobiliary GI tract. Mortality rate is 20 to 70% with rupture. It's also important to differentiate the true aneurysm from a pseudoaneurysm. The treatment for these is recommended for any symptomatic hepatic artery aneurysm, any pseudoaneurysm, or any true aneurysm that's greater than 2 centimeters in an appropriate surgical candidate. Historically, this has been treated in an open manner with either excision or ligation with or without a bypass graft. More recently, we've been trying to treat this endovascularly. Ideally, this is suited for lesions that are within the parenchyma, although there's more recent studies showing this also in the extra hepatic space. Our patient is a 56-year-old black male who's referred from his primary care physician for abdominal pain, obstructive jaundice. He reported it for like the last month before he came in. He'd been having epigastric pain, an episode or two of nausea, vomiting, as well as noticing jaundice in his eyes, dark urine, and pale-colored stools. He has no significant past medical or surgical history or any significant family history. He has a six-pack of beer a day and smokes a pack of cigarettes a day. On exam, his vitals were normal. Blood pressure 124/73, heart rate 83, afebrile. He's tall, 6'6", 164 pounds. Gives him a BMI of 19. In general, he is tall, thin, black male. He has in no acute distress. He has scleral icterus and tenderness in his right upper quadrant, but no palpable mass. His labs that he came in with, he had a normal white blood cell count, normal hemoglobin and platelet count, a bilirubin of 32, as well as elevated AST, ALT, and ALK phos being 1590. Pancreatic enzymes are normal. This is a couple of shots from his outside non-contrast scan, which suspected a possible pancreatic head mass. You can see the kind of moderate intrahepatic, extrahepatic biliary ductal dilatation within the liver here, and then extrahepatic. And then, you see the calcifications of hepatic artery here, and then possibility of the aneurysm in the hepatic artery there. Given the severity of his jaundice, he was admitted to the surgical oncology service at that time. GI was consulted, and ERCP was performed with sphincterotomy, common bile duct stent, and biopsy. The biopsies turned out to be negative for malignant cells. With the stent in place, the bilirubin trended down pretty quickly, almost to normal. The next week, after this was done, a CT angiogram was performed. A little bit better delineates it for us. Here we have the aorta, the celiac taken off, and then as it comes across, we see this large, nearly 3 centimeter hepatic artery aneurysm. Here's a 3D reconstruction picture. So, with his bilirubin trending in the right direction, he was then sent to our vascular surgery service for treatment of the aneurysm. We discussed with him the options of open versus endovascular surgery, and after a thorough discussion, opted for endovascular approach. We gained access to the right common femoral artery percutaneously, and originally shot this aortogram, which reveals celiac, and then the hepatic artery aneurysm here. Here's another shot from within the aneurysm itself. One of the key things here is the size of the hepatic artery proximal and the size of it distal. I guess we considered, at least in clinic, putting a covered stent across it, but due to the size discrepancy, decided that wouldn't be feasible. We began by placing coils distally in hepatic artery, then in the aneurysm itself, and then proximal. A final angiogram was obtained. I thought I had a picture here, I guess I don't, that showed resolution, no flow through the aneurysm or distally to it. He did very well. The procedure was done with monitored anesthesia care and local lidocaine in the groin. The procedure time was about 2.5 hours, and he was discharged post-op day 1. His LFTs continued to improve from after our procedure. 2 weeks after the embolization, his common bile duct stent was removed by the GI team, and he's been seen in clinic since. He says his abdominal pain is gone, and now all his LFTs are within normal limits. That's it.